and for us to acknowledge those, to be aware of our own sense of uncertainty and fear, as well as hope and solidarity. And so we thought it was appropriate to ground ourselves this morning in a spirit of gratitude, with a quote from Winston Churchill that some of you may be familiar with. Never was so much owed by so many to so few. And so we're grateful for your partnership and intimate connection to us, for the many caregivers that are making great sacrifice, and for the ways that together we share a collected vision of health for a better world.
Thank you, Juliet. So I'm not sure if Renee has come back on, but I would like to go ahead and get started. As I said, this is Kelly Linden. I hope that you can see the five of us on your screen if you have logged in or can hear us on the phone. If you cannot, please just let us know. We can, or text Renee, and we will be sure to correct that. So I want to start by thanking all of you and our community. The outpouring of love that we have received has been extraordinary. The generous donations, the sharing of food, the support of our caregivers, who we are so extraordinarily proud of, and our physicians, has been immense. And so I want to say thank you to each of you. I also want to acknowledge and thank our caregivers and our physicians, our providers, who have truly stepped up without exception to provide during this really unprecedented time, a time when there's fear, there's unknown, and yet our staff have been there every single day, every single night from the first moment that we started planning for this. I want to thank our leaders as well, who have really worked tirelessly to ensure that we're prepared, that we are doing everything that we possibly can to care for our community and to care for our caregivers and physicians. I would say for the last probably 4 or 5 weeks now, maybe five or 6 weeks, have been preparing to ensure that we are ready for any needs that our community would bring forth to us. And we started early on modifying our emergency department processes, modifying our triage and screening. We set up tents to ensure that we could segregate patient populations so that nobody would be at risk. And then started to see a surge in our census, our COVID census. And there's 2 types of patients that present. One is what is called a person under investigation. They're called PUIs. And they are individuals who have been tested for COVID, who are showing signs and symptoms, but we don't yet have the results. And then there are those patients who are positive for COVID, and those are individuals who we've received test results. When we started this process, our lab testing, the turnaround was taking between 5 and 7 days. And so as a result, that impacted how long we had to wait until we knew whether an individual was COVID positive. But in that early response, we started to modify our facilities, expand our critical care capability, ensure that we could cohort patients in our South building, and that we had staff and supplies. And we're going to talk a little bit more about that as we go through. So as we go along here, I wanted to ask each of our leaders to share with you some of the things that have been going on. And I was hoping that, Darren, you could talk a little bit about the many units, what we did to prepare for the surge in patients, the volumes of patients that we might see, and how that process went forward.
Yeah, thank you, Kelly. Good morning, everyone. So in preparation as we've worked through this pandemic, we have made some pretty dramatic changes with our patient flow, and that's really to keep our caregivers and then patients safe as they move through this. Our biggest changes you'll see are in front of our emergency department. And so historically, you would present to the lobby. In the lobby, you would be screened or triaged and then brought back to the ED. Today, we have two screening tents out under our ambulance bay, and that is where we screen patients and then identify if there is a person under investigation that we feel is meeting the clinical criteria. They are then brought right back into an isolation room. So they're not mixing with the general population for us. We've also, for those familiar with our campus, we're really blessed to have additional space. And so we have a south tower, and in that is where we have been cohorting our COVID patients positive and then people under investigation. For us, that's worked really well because we can then consolidate our equipment, centralize our what's called PPE, personal protective equipment, and really try to create an environment collectively where we're caring for all patients the same way. And so in that, we have what was our third ICU has turned into our positive ICU. And so that is caring for all of our COVID patients. And then we've actually expanded our ICU into 6 South. And so that has given us a lot of breadth of expansion for us to cohort our COVID patients and then keep them separated from our north and northeast tower of other patients receiving care, non-COVID. The other things we've done is 4 South was our med-surg unit. We've actually turned those all into what are called negative pressure rooms. So the windows actually look a little different on the outside. What a negative pressure room, to put it in perspective, in your air conditioning at home pushes air into the room, so that's positive pressure. A negative pressure room pulls air out. And so we have negative pressure units in every med-surg unit, pulling that air out to the outside. And that has been seen as a best practice in how we care for patients. We're also, you'll hear a lot of talk about ventilators. We are really, really fortunate. We were doing a switch out of our ventilators from the ones we've been using to a newer version, and actually hung on to those that we were switching out. So we are well prepared. We have 109 ventilators. Right now, we're barely even using half at this time. And so we've been working with the other hospitals to determine their need as well. But we're very, very blessed to have the right equipment. But I hope those will kind of share some of the changes we've made here in the hospital to work through this.
Thank you, Darren. So one of the questions that I know that many of you are asking is, what's our volume look like? Are we prepared for a surge? And what I'll share with you is that last week we were running a census of COVID positive patients of around 25. It would go up a couple, maybe come down a couple, but around that level. And then our persons under investigation was running also around that same number, 20, 23, 25, 27. And what's been interesting about that is that was a surge that we saw about 10 days ago or so, and then it leveled off. And the reason this leveling off is important is you've probably heard out in the news this discussion of the peak and the apex and how steep the curve is. And what's been very fortunate for us, and what we're seeing actually across the region, is that we're somewhat flattening on the top of that apex, which is potentially where we think we are. And that's important so that we recognize that if we continue to do all that's being done in the community to socially distance, that it is in fact working. And that gives us, our hospitals, the opportunity to have the capacity, have the ventilator needs to meet the needs that we are seeing. The other interesting thing that we're seeing is that just this weekend, we were able to bring our own in-house testing into the facility for our laboratory. And the reason that's important is we don't have to wait the 2 or 3 days it was taking recently to assess whether individuals were COVID positive. And so our persons under investigation has started to drop, and we can care for them in non-COVID units appropriately. And so if we can continue to see that flattening of the curve and sustain at these levels, then we can certainly manage our surge capacity. But also to what Darren has mentioned, should our demand go up higher, we do have the critical care capacity. We're very fortunate to be able to convert beds to additional critical care and telemetry capacity. And so we are prepared should that occur. So Liz, I'm wondering, can you talk a little bit about how many patients we've tested and how many of those are positive, what we're seeing in the ministry?
Sure, thanks, Kelly. So as of last Friday, April 10th, we have tested 668 people, and that has been since the 1st of March. 108 of those are positive. Testing occurs mostly in our ED, and we test patients that are generally symptomatic. So they're experiencing cough, fever, shortness of breath, and we admit the ones that need to be admitted, which is nearly about half of those 108 have needed critical care because they've been sick. Also, don't forget that it is also flu season, so we're seeing a lot of flu-like symptoms as well. So that's why not everybody is testing positive for COVID, but we do test them. Also, our testing has been, like Kelly said, exciting that we have it in-house now, and we're able to turn that around in less than 2 hours. So it has really helped a lot with the amount of patients that we're able to see. The patients that get sent home, mostly are persons under investigation, and we're able to send them home with a kit that has a thermometer and a pulse oximeter. So if they're short of breath or they're experiencing fever, they can check in with our home health care team and do next steps. But it's been very helpful for us to be able to send some of our patients home so that they can self-isolate at home as opposed to being in the hospital.
Thank you. So I think everybody on the call today has heard the news stories in New York and how difficult it has been. A lot of conversation around personal protective equipment, the PPE, the masks, the gowns, the gloves, N95s, PAPRs. And I'm wondering, Liz, can you talk a little bit about what we're doing to care for our caregivers, care for our physicians, make sure that they're safe and that we have everything that they need?
Sure, Kelly. So we have been very, very fortunate, as Kelly and Darren have both stated, that we work in a hospital that is part of a larger system. And so we're able to work within our region as well as in the system to move supplies around as we need them. We really haven't had the experience like New York has had where we've actually run out of a lot of equipment. So that has been very fortunate to us. Some of the things we're doing for our safety, we have a safety monitor for every 3 or 4 patients, especially in the ICU, that really watches caregivers don and doff, which means they take off their PPE and put it on to make sure that everyone is doing it safely and per the recommended guidelines. We've also adopted iPads to talk with our patients so that people are not going in and out of the room as much. That also conserves our PPE, but allows us to actually talk to our patients without going in the room and disturbing them. Darren talked about our negative pressure rooms, which we are extremely fortunate to have that many across the nation, if you will. Most hospitals have maybe 1 or 2 negative pressure rooms per unit, and so we actually now have units that are all negative pressure. So that has been an added bonus for us. A very creative thing that we did, because we have our COVID units are on units that were built in the 60s, 50s, and so the doors are actually real wood and they're very, very thick. So it's very hard to hear what's going on in the room. So we've actually worked with our construction team to install visqueen doors, which are that plastic sheeting that construction companies use. And we've actually been able to put zippers in it with a little window so that caregivers can hear our patients and actually see them without having to don all of their PPE to go in. I know we've mentioned that we have units designed especially for COVID, and that has been extremely helpful. We've also had, as Darren mentioned, our ICU capability. We've gone from 34 typically ICU beds to almost over 100 if we need them, so we're definitely prepared for that. And our med surg and telemetry also, we have plans to expand if needed. So I think we are really very, very prepared. We've also been working with a company to help us with our staffing called AMN, which partners with the ministries in the region to help make sure we have staff when we need them.
Thank you. So I want to speak a little bit more towards the PPE, the personal protective equipment that you're hearing across, really across the country, the concerns and the shortages. And I again want to say what I said in the beginning, which is thank you. We have had some extraordinary gifts of actual physical PPE, masks and gowns, gloves that have been sent to the ministry by many of you on this phone, as well as others. We also have the good fortune of being a part of Providence, who is able to move those supplies, as Liz said a moment ago, across the region where there are shortages or needs. But I want you to know that the work that you are all doing and the support that you are giving us, both financially and through actual physical assets, is really necessary. It's exceptional. It is what's making the difference for our caregivers and our physicians. And so all of that support, I want you to know, is going towards this work. It is ensuring that we have the equipment that is needed for our staff, and so it is making an exceptional difference. Darren, I'm wondering if you can talk a little bit, and I've asked Juliet to chime in as well. Talk a little bit about the universal mask. I see that you've just taken yours off. You might all notice, if you do see us on camera, that we are 6 feet apart, and we are wearing our mask when we're not speaking. But Darren, if you could talk a little bit about our changes in the universal mask process, masking out in the community, what they should or shouldn't be wearing, and then the impact on our visitors and how that's affecting those that we care for.
Yeah, thank you, Kelly. I will say I don't have to shave every day now with my surgical mask, so I appreciate that just for a few days.
You will with an N95 then.
Right. So there have been some changes, and these have been hard to implement, especially regarding our visitor, and I'll have Juliet kind of chime in on that. But for our staff, what we have mandated is, in alignment with the county and the city, that everyone is with a mask here in the hospital. It's a surgical mask. We're also scanning all visitors, all physicians, and all administrators' temperature as you walk in the door. So if you have a temperature at over 100 degrees, you are turned away, and that includes caregivers, because we have to protect the health of those that are here in the hospital. So those have been the big changes, but the biggest one also then is the no visitor policy, and that's in alignment with the governor's recommendation. We have made a few exceptions, and one of them is end-of-life care, and I'll have Juliet speak to that.
So as you all can imagine, it's extremely difficult to implement a no visitor policy, but so essential for the safety of our patients and the well-being of our caregivers, as well as the larger community. And that we recognize those exceptions, as Darren said, that were so vital. So we still have, in particular, we still have babies being born, and we do have one particular person that comes with their partner, so they have someone to be with them who is then also appropriately screened. And then we do have end of life realities, but we want to be able to be compassionate at the same time that we're still implementing those safety protocols. So we have been able to have one person come in for a shortened period of time, still having been screened, to be physically present if they can for our non-COVID patients, to then be able to touch base with their family, to rotate a second person when it was essential to the community. And we've been just companioning all of our families in those end-of-life care moments, as well as the complexity beyond the walls of the hospital, where they're altering the ways that they are able to gather or not gather for celebrating life, for funerals and memorials. And so our spiritual care team has worked vigilantly with companioning our families as well, to be able to think of other ways that they can be connected and be able to remember and honor their loved ones.
So some pretty big changes here at the hospital. We also really miss our volunteers, as we've had to put a pause on our volunteer program, and you just continue every day to realize their worth here within the ministry. Hopefully one day we'll be excited to have them back. Also, our gift shop has remained closed as well. And so we'll be excited to hopefully one day bring those back.
Very soon. So Howard, as a chief medical officer and partnering with our physicians and looking at how we're caring for our patients, there's a lot of conversation in the news about the antibody testing, the screening test, a lot of conversation about the clinical protocols to take care of patients, some investigational work. Can you talk a little bit about what we are, what we're doing and kind of where we're at both in testing and the antibody test, and then also about clinical care?
Sure. Before I answer that, just a couple of points. We've been quite busy here with COVID patients as opposed to the rest of LA County. If you go to the west side of the county, the hospitals there, Tarzana, Northridge, West Hills, aren't seeing a lot of COVID patients. On the other hand, we had quite a few. And it turns out that Glendale is sort of a hotspot for COVID. And I know Glendale Adventist has seen quite a few patients. It's sort of interesting about this disease, it's very spotty. But despite the fact that we've seen, quite a few patients, we've really managed them well. We have the space and capacity, and we're able to segregate the patients into the South Building, which you've already heard about. And we're treating some of these patients according to various protocols. You all know about the hydroxychloroquine protocol. Most of the patients get hydroxychloroquine. For some of our severe cases, we were participating in the remdesivir trial, and we've used that a number of times. And the newest thing is the plasma therapy, convalescent plasma, where you take the plasma from a recovered patient and you transfuse it into a patient who's seriously ill, and that is just getting off the ground. Working with the Red Cross on that, and that will probably be starting this week. A couple other things that we're thinking about. Today is really D-Day when it comes to the surge. According to the most reliable epidemiological surveys, which is I'm sure you all look at the IHME at the University of Washington. They're predicting that for California, today's the day of maximal resource use. I think the death rate is supposed to peak on Wednesday. But we've seen a marked leveling off of our cases, and to the point where we're starting to look ahead. And some of the things, we closed our ORs, especially to elective cases. We're only doing emergencies or cases that can't wait. And we're starting to do some planning to reopen our ORs as soon as safely possible. We have to develop processes around that. Obviously we want to test the patients, we want to safeguard our staff, but I think there's a little bit of light at the end of the tunnel when it comes to getting back to business as usual. The other thing we're looking at is one of the things that is really helps preserve the PPE, but also helps safeguard our caregivers, is when we don't need to go into the COVID patient's room. We can often communicate with the patient through telehealth, and we're using iPads for that. The other platform that we're going to use are robots. We have what we call InTouch robots, which are little robots you can wheel around. They have a camera and a screen, and you can communicate with the patient via the robot. And we've just ordered a few of those, and Providence is sponsoring a program where the ministries are all getting a certain number of robots. And the other thing that we're looking at is, the ER, it's sort of interesting what's happened to it. Our census has dropped. Hospitals is not as full as it usually is, and our ER especially is not as full as it usually is. So we're looking at telehealth options, for the ER as well. Perhaps if the patients aren't coming to the ER for face-to-face visits, they can communicate with the ER via telemedicine, and we're also looking at that. And then the only other thing I'll mention is since a large number of these patients, these COVID patients, are on ventilators, and what's interesting about this disease is that the time that they spend on the elevators is really prolonged. It's a week or 2 weeks before they get off the ventilator. Because of that, we use a lot of our drugs that are sedative drugs, propofol, neuromuscular blocking agents, things like that. And so we have to guard our supplies of those carefully in order to make sure we have enough, for this unusual disease. And we're also looking at, alternative drugs such as ketamine for those patients. So that's sort of, where we are, clinically. Again, I think we're in better shape than they were a week ago, and I think there is some light at the end of the tunnel.
And Eric, one of the questions that has come up that was shared with me is a question on mortality. And I think we've heard stories, of course, across the country and here in California. Can you talk a little bit about what we're seeing, types of patients, those that most at risk?
Yeah, well, like everybody else, patients, most of the patients that we see who wind up in the ICU are from nursing homes or, in an advanced age. We've had a few young patients. We had one that was on the ventilator for over a month. So while the curve is highest with the elderly, just because you're young doesn't mean you can't be infected with this virus.
And we have seen mortality in our hospital,
yes,
of
we
course.
have.
So like we have in other hospitals as well. One of the questions that I can speak to and others can add in is this question of our caregivers and our physicians and exposure, and have we had any exposures? And I will share with you, I don't have specific numbers that I can share today. We have had a few across the region. There have been a number, but I will tell you we have been very, very fortunate. The number is very low. We think that our protocols, our processes that are in place are working exceptionally well. But I want to start by saying that one caregiver, one physician is too many. And so everything that we're doing is working to protect our caregivers, our physicians. But I also want to remind you that this is community acquired. And again, that social distancing is so important, but it also impacts our caregivers who are out in the community. And so we have seen examples of community acquired COVID as well. So that is something we are watching very, very closely. We are ensuring that our protocols are working effectively, and I'm very happy to report that across the region that is in fact been the case. Another question has come up about the resurgence. And so if in fact we have seen a flattening of the peak, so to speak, and we are going to see that sustained over the coming weeks, what's going to happen if we start to loosen up our requirements in the community and open up the country as being discussed? And there are many individuals who are working on that, clinicians and economists and everybody making those decisions. But the concern that was questioned, and I'll speak to, is what if there's a resurgence? And that's something that we are looking at very closely. As Howard mentioned, looking at how we bring surgical cases back to the ministry, elective cases. We need to do that safely and appropriately. We need to make sure we have the right supplies, that we have the right pharmaceuticals, as was mentioned, that we have the right staff, and that we are still prepared should there be additional demand from the COVID patients going forward. And so to the earlier comments, we definitely have the capacity to manage that. We are ensuring that we are prepared for that. We are not letting our guard down, despite also looking towards our future to be successful. And the other question that was brought up was this question around testing in-house and how fast. So as I mentioned, last Friday, we were able to bring the Abbott technology into the ministry, that we can do testing in-house now. That testing can be turned around in just a matter of hours. And I think, Darren, are we seeing a couple of hours in turnaround?
Yeah, we're seeing a couple hours right now.
Yeah, so that has made a big difference. But I will caution you to know, or share with you, is that we have very limited testing kits. And the reagents that are necessary. Each of our ministries have been given a daily allocation. And so as that allocation begins to expand, then we can expand our testing, and that can allow us to do some other things as well. Are there any additional questions that? So the question is, that was shared is, how has COVID impacted the other areas of the medical center? Well, first of all, I'll share, as we already discussed, and that is that we are able to cohort our patients into one tower, which has worked out very well for the ministry. Secondly, as you know, and what was already shared from Juliet and Darren about our visitor policies and our structures to ensure that we have an organization that's protected, that we're protecting our caregivers and physicians and our patients and their families, those changes remain in place. And so that certainly has had a big impact on the ministry. And then the last piece I'll mention, and again, Howard had shared this, is that our census, non-COVID related, has dropped dramatically in the emergency department and in the hospital. Because we chose proactively to cancel non-urgent and non-emergent cases, surgical cases, those patients are not coming to the ministry. Our ED, our emergency department volumes have also dropped. And so it's really important that we have a strong plan in place, that we can plan for our future over these coming months, so that we have the ability to bring cases back into the hospital. And in terms of how long we might keep the South Tower segregated for our COVID patients, that's something that we're actually assessing as we speak. We want to make sure that we are planning for the summer months and the fall months. There is an anticipation at this point that there will be, whether you call it a resurgence or a new season, until there's a vaccine available, we do anticipate that we will continue to have volumes that will be needing to cohort patients. And so we will look at whether that South Tower is the area that will be utilized or find other mechanisms to do that. But we are in the process of assessing that at this point. So Renee, are you back on the line?
I am, and of course, my internet went out for the 3 minutes I needed to speak in the beginning of the presentation. But all of the questions that, the additional questions that came to me by text, I already shared with you and you've already answered. Because we still have a little bit of time before we end, I just want to know if there is anyone on the line that wasn't able to text me, and if there is a question that you might have now, you can unmute yourself and ask that live.
Hi, it's Mark Schoon. I'm just curious, are you doing any of the antibody testing that I'm reading about? Thanks for the answer.
Not at this point. The antibody testing is just being developed. There's an NIH trial in LA, and I think that's the only place in Los Angeles where they actually are doing antibody testing, but not here, not at any of the Providence sites.
And I missed one of the questions that Renee had sent over our way, and that was a question about drive-through testing. Some of the medical groups have implemented drive-through testing, which is the appropriate location to do that when they had the test kits and swabs and the ability to actually implement those programs. And in all of those cases, they were required that you have symptoms. It was not for asymptomatic individuals. And those things I think you'll continue to see expand as needed. The hospital will not be providing a drive-through clinics for those sorts of things that we handle through our medical groups or physicians, or may be done at a regional level when appropriate.
Providence does have a platform called Express Care,
Yes.
Where if you download the app, it'll get you hooked into one of our many healthcare clinics that are not close to the hospital. And since this COVID epidemic has begun, Express Care has really become busy, and I imagine a lot of testing will be done through the Express Care facilities, including the antibody testing.
Yeah, good point. Other questions from the group? Renee, we'll turn it back to you then. And I again want to thank everybody for just your extraordinary generosity and support as we go through these unprecedented times.
I would like to echo that as well. Thank you so much. It really, truly, oh yes, is there a question?
Yeah, Renee, I just want to thank you for the robots.
Oh, well, that you don't thank me, thank the philanthropy that we were able to raise in order to be able to do that. So Thank you so much for the overwhelming support that we have received in order to be able to do that for our hospital. That is what we're here for.
Renee,
Yes.
one more thing if I can add. I hope that if you have an opportunity to drive by the campus, you have had the ability to see our signage that's been put out. It's Heroes at St. Joe's, and it says Heroes Work Here. And it was our very small way to tell our caregivers and physicians how much they are appreciated, and appreciated by the community, and appreciated by all of us. So if you have a chance to thank a caregiver, please do.
Absolutely. And again, I just wanted to say thank you for those that have supported us. Thank you for those who have provided the supplies and protective equipment. We need it. As Kelly said earlier, you know, while we're ordering these supplies and we want them, and we're ordering more than we need right now because we are anticipating the supply chain shortage. We are seeing supply chain issues. So in addition to that, we are going through PPE much quicker than we could possibly have imagined. And while there's the surge that's happening now, whether we have plateaued or not is to be seen. There is, as Kelly and others have mentioned, a possibility for this to be seen again in the fall. And we are in unprecedented times, and we do not know what we will be experiencing and seeing. So I just wanted, yes?
Oh, this is John Giroux. How are you? Kelly and Renee. This is a great presentation. This is proof that this is why we need that ER. And when that's completed, we'll be much more well-equipped to handle things like this.
Well said.
Well, I think with that, I will let you know that we are recording this, so it will be offered for you to listen to and to share with others that may not have be able to be on this call, but would like to hear what is happening at our medical center. I want to thank Kelly Linden. I want to thank Dr. Howard Davis, Elizabeth Paxton, and Darren Goss for doing this for us today and being able to provide your expertise and share what we are experiencing here. Juliet Marsh, I also want to thank you for delivering that reflection. And with that, I hope you all stay safe, continue to be healthy, and if you need us, we are here for you. Thank you.
Thank you, Renee. Thank you.